I'd like to introduce our next speaker. It's Dr. Janis Blair, who's a professor of medicine at the Mayo Clinic, Scottsdale. Janis has done a phenomenal job in working on coccidioidomycosis, particularly in transplant patients and patients with other immunosuppressed diseases. And we're very thankful that she joins us. And so she's going to talk about managing disseminated disease.
And thanks again to the organizers for allowing me to participate in this. It's an honor and a privilege. Today we'll go over treatment of coccidioidomycosis, and I will try to fly through some of the stuff that Dr. Impel has already touched on, and some of it I think is probably worth stating twice. So I am aware that we will do some overlap here. I have no conflict of interest to disclose, but I do need to let you know that almost everything we're going to be talking about today will be FDA off-label. And the only FDA-approved medications with an indication for cocci are ketoconazole, if you're so inclined to use that. And there are times when that may be something you want to do. And the old-fashioned amphotericin B deoxycholate, the hard on the kidneys, put them in dialysis in 3 days sort of thing. Those are the only ones. Everything else is going to have an off-label indication. So we start off treating cocci with a very careful history and physical exam. One of the things you need to do is define the severity. That won't be hard to define, but also the location and the chronicity of the infection, because by answering each one of those aspects, you're going to have a better sense of the type of treatment you're going to need. And you especially want to know if there are if there's any evidence of extrapulmonary cocci. So we need to know if it's in the skin and the soft tissues, bone and joints, or the central nervous system. So I'm going to camp a little bit on the therapeutic agents that we have in our armamentarium here. And I just want to make a plug. It is perfectly acceptable and actually probably recommended that for mild cases of cocci, primary pulmonary cocci, especially, and I use Dr. Empel's rule too, if it's already getting better, by the time they see me, I don't use antifungal treatment. Dr. Impel has already gone over his data showing that it doesn't decrease the rate of dissemination or complications. So what about amphotericin B? It was the first medication that showed any efficacy against the coccidioidomycosis. It can be given IV, intrathecally. You can inject it into a lesion, into the joint. But the only thing you can't do is take it orally and have it be absorbed. The IV was known early on not to be effective for cocci-meningitis, and back when we were using it for cocci-meningitis, it had to be given intrathecally. It has this perception. There has never been a trial of amphotericin B in cocci infections. It was just the first thing that worked, so it got used. And some people have this idea, and I have to say, you always feel better if you have a patient who's rapidly running away and declining with cocci. Feel like you're doing something more if you give that amphotericin B, but we don't have any studies showing that is a true to life situation. And so if you're going to use the old deoxycholate preparation, the dose would be 0.5 to 1.5 milligram per kilogram. You can give it daily, or if they're struggling with renal insufficiency, every other day is fine too. It is fraught with toxicity. It's hard to take when it's going in. Patients will frequently, as it's being infused, have fever and rigors, hypotension, lots of symptoms. And then, of course, the cumulative toxicity is that the creatinine starts going up and the patients will waste potassium and magnesium. The lipid-associated amphotericin Bs have pretty much taken on the market when we do use an amphotericin, and they were developed as a safer alternative to the first round of amphotericin. There are 3 formulations that are available in the U.S. and amphotericin B cholestyryl sulfate complex, amphotericin B lipid complex, and liposomal amphotericin. It all depends on what the configuration of the lipid molecule is. There still are acute febrile reactions, though they are less frequent, and some formulations seem to have less of the febrile infusional reactions than the others. All of them have lower kidney toxicity. They're all expensive. And again, there's no data that compared the lipid formulation with the old-fashioned amphotericin B or that one is better than the other over azoles. Now, the azoles as a group, especially compared to the amphotericin B, relatively easy to take, lack toxicity, by and large have good oral bioavailability, and they are tolerable for the long run, and some of these patients do need long courses. And these we do have formal studies to show what the efficacy of these agents are, but there aren't any studies that show clear superiority among the azoles, with one exception that I will point out. So I'm not going to say too much about fluconazole. It's been on the market for a long, long time. It has very good oral bioavailability. In cocci, we usually treat with 400 milligrams, and often when we start with meningitis, we'll double that. It is useful to treat many, if not most, of the coccidial infections that you see on a day-to-day basis. It's relatively inexpensive. I just pulled this price off the Mayo formulary. You might be able to get it cheaper than that. I'm sure you can. But that's what it costs us. And on occasion, there is an infrequent hepatitis, seems to be more common in certain demographics like bone marrow transplant recipients. But in general, for the everyday run-of-the-mill cocci, if you decide to treat, this is a very, very good agent. Now, itraconazole, also available orally, does require gastric acid for absorption, and because there is this issue, you do need to measure the serum levels to make sure you're actually getting it delivered to the area that you want it to. The dose is 200 milligrams twice a day or 3 times a day, and it ought to be cheaper than it is, but again, I just pulled this pricing off and found that it ranged between $10 and $94 a day, which I thought was a lot. It is well tolerated, and this is the only this is the only agent that has shown any superiority one over the other when fluconazole and itraconazole were compared in extrapulmonary cocci. Itraconazole was superior when compared to fluconazole for skeletal cocci. Now, I realized after the fact that probably the next couple of slides I'm going to put too much information on. You're going to think this is a more important agent than it ought to be, and really I'm just putting some thoughts down because the voriconazole and posaconazole are newer agents. The role in cocci here is really not clear. It has been used successfully for salvage cocci, but it's not always successful. And in our recent look-back study, we found it to be successful over whatever they were switched from about 2/3 of the time. The in vitro susceptibility is better than the level of itraconazole. It's got good tissue penetration, good CNS penetration, and it's got a PO or an IV dosing. So it does have some help. But voriconazole has some issues too. The therapeutic levels do need to be absorbed, and although the bioavailability is pretty good, the metabolism by the CYP enzymes, there can be some heterogeneity within the population. So the same dose is not always translated to the same serum levels or even equivalent serum levels among patients. And there is a study that suggests that as you take it over time, there may be lower and lower and lower serum levels. So you have to be careful with this agent and watch that aspect. the more I use this in a salvage situation, the more I'm impressed with how difficult of an agent this is to use for the long haul, because patients get these phototoxic skin reactions that can be very impressive. I just had a patient finally go off after months of this terrible phototoxicity. She was getting a derm workup for all kinds of things when, in fact, it was the voriconazole, and it started months after we initiated the treatment. So it can be a little deceiving. Now, I have here again the daily cost. Oral, it is expensive, and a lot of patients, hand me back the prescription and say, I can't afford it. Posaconazole, again, the role is not clarified at the present time, and there was a little bit of excitement because when it was fed to the rats, whoever got it in the lab, it looked like it was killing the fungus, which would be such an enormous advance over what we've had in the past. However, I think as we use it, I don't see the same excitement with that. It is only available in a liquid suspension, which limits some people. That becomes an unacceptable thing. Though the drug company says it's pleasant and cherry flavored, most patients are like, not that good. It does require a fatty meal for absorption, and although it has a really nice long half-life, it has a saturable absorption, so you have to dose it multiple times per day. It is not going to do okay with a once daily dosing. And the other thing is that penetration in the CNS seems to be quite variable. So although it has been used in coccimeningitis, it's something that you need to be aware that it may not be, at least theoretically, efficacious. And again, this one is expensive. Posaconazole does have studies showing that it satisfactory response, 85% in open label, chronic pulmonary, and non-meningeal cocci. There's also been studied in chronic pulmonary and disseminated patients who were failing other agents, about 73% success, which is about what we've seen as well. And 12 of 16 patients improved in salvage therapy. So there is a little more data here, though every study is very small. And I did mention ketoconazole. It's one of the two that has an FDA indication for cocci, and it might be something you would want to consider when resources are extremely limited, because this one is really cheap. I take 400 milligrams daily, but we all are familiar with the fact that the reason it's not used as an antifungal anymore is that it can have significant interaction with testosterone production and cortisol responses, then making it a really good thing for prostate cancer. But it is a problem with cocci. So echinocandins are the sort of come up every once in a while, and I'll say this, there's no good human studies to show that it's going to work as a sole agent. There is one animal study that showed when you combine it with something else that we know works, amphotericin, that there may be some efficacy there. And there's limited case reports where they added caspofungin to something else, and I'll say that the case report mix is just, we don't know. There's no clear message there. So there's no recommendation for its use at this time. Nicomycin Z is something we're all hoping to see sometime in the future. It's currently under development at the University of Arizona here. And the phase 1 studies looked good, safe and well tolerated. Phase 2 is not yet started. We're real excited to see it, hoping we'll get that started in, I'm told, May of 2012. Well, combination therapy is an idea that's been, tossed around, and again, it's not uncommon to see when someone is on an azole and doing poorly, they throw amphotericin B and see if we get any better response. And that's not uncommon to see that thing happening, but there's no formal studies to tell us that two are better than one. There is a hypothetical risk of antagonism, but that has never really been borne out in other fungal infections where that issue has been studied, and it's never been seen as a clinical issue. So I think this is an area that might bear further evaluation. Sometimes the best way to deal with cocci is to cut it out. And situations where you might think about doing surgery for that, when you have a large abscess, when you need source control, when you have something progressively getting worse despite antifungal therapy, when you're having a destructive lesion, such as in this in the bone, unstable spine, or things like that, when your cocci is impinging on something that you really don't want to live without, like an aorta. Surgery is a good idea. And sometimes we just get to the point where, even in a little cocci nodule, they've tried, relapsed, we just cut it out. That works good too. So the rest of the time I'm going to spend going over the IDSA treatment guidelines. They were published in November 2005. I expect that we're going to be seeing something more revision-wise in the near future. And in order to go through a rather dry guideline, I'm going to try to illustrate some of the concepts with some cases. So the first case was someone that we saw, a 74-year-old lady with hypertension and hyperlipidemia, and she had a subacute onset of headache, cough, shortness of breath, and a pleuritic and non-pleuritic chest pain. She was fatigued and malaise, chills, night sweats. She didn't have any fever. And when she was initially evaluated, she had a slightly elevated white blood cell count at 10.2. She did have eosinophils, which was a tip-off. Sed rate was elevated, chest x-ray was performed, and the initial cocci EIA was negative. And she just happened to have a baseline chest x-ray 1 month before she got symptoms. And in the right lung field there, you could see the new cocci density. And a CT scan was performed subsequently, and you can see the nice nodule with some satellite lesions, very characteristic of cocci infection. Well, she was diagnosed actually clinically with acute pulmonary coccidomycosis, and later the serology turned. Because she was already getting better by the time that was confirmed, we did not treat her. The nodule was followed, was stable, and didn't require any further treatment. So IDSA guidelines show if you have absent, mild, resolved symptoms, no antifungal therapy, but periodically reassess. And I think Dr. Empel stressed that nicely. If they're immunosuppressed, to say immunosuppressed sounds like it's a one-size-fits-all. Some I would consider treating, others I would say very definitely treat, like the kidney transplant, but for all, they need to be followed very closely. So case 2, a 48-year-old woman who's very healthy, came down from Minnesota, landscaping her Arizona home in December. 1 week later, comes down with fevers, chills, sweats, cough, shortness of breath, headache, etc. We know the drill. And this time, because she's sick, she was admitted to the hospital. And we happen to have an old x-ray on file 1 year earlier and can see that now she's got right greater than left, but definitely bilateral pulmonary infiltrate that rapidly progressed. And she so rapidly progressed that she went on to intubation, required mechanical ventilation. Of course, we don't say, hey, this is cocci, and that's all we treat. She got very broad antibiotics. Her sputum culture did grow coccidioides, as well as a conversion of her serology. She was given ambisome initially up front and was later changed over to fluconazole and did very, very well, other than the fact that she may never be back to her winter home again. So where we said in mild to absent resolved, really kind of nothing, not much going on, no treat. In moderate or severe infection, you definitely want to be administering something. If you have a rapidly progressive or severe case, then you'll want to be administering amphotericin. And if something's slightly less than that, and you're comfortable with fluconazole orally, then that is what I would consider, the drug of choice. Itraconazole is also perfectly acceptable, though I would mention to check levels. Okay, but how do I know the difference? If they're not better, do I treat or do I not treat? And Dr. Ampel has already kind of gone over this. The IDSA guidelines do have qualities. If your patient meets any of these, you might say, okay, this is someone that probably needs some treatment. We did a look-back study that is not yet published, and it was just, who did we treat, who did we not treat? Mayo patients, and so it is what it is. 322 were reviewed, and 190 were treated, and those were hospitalized, diabetic, immunocompromised, etc. But I'm focusing on the 113 who didn't get treatment, and 88% of them did very, very well. So again, I'm going to reemphasize Dr. Ampel's point is we don't actually have to treat every case of cocci. Now, 2 of them had a poor outcome. Was it recognized as cocci fast enough? They were already immunocompromised and did poorly. And 7% had relapsed cocci, and those were people, again, who did have risk factors for having a problem. They were either had diabetes mellitus or, again, were immunosuppressed in some way, shape, or form. But if you look at the vast majority of otherwise healthy people, again, another piece of information that, hey, supports that we don't have to treat them all. But there's lingering questions. A randomized trial of primary pulmonary cocci, placebo-controlled, has never been performed, shockingly. And so the question is, if you give it, won't it speed up the illness, resolve it faster? And it seems like it ought to, right? Well, we don't know the answer to that question, and hopefully someone will be able to answer that question for us somewhere. But part of the problem is a diagnostic test, because it's very hard to diagnose early on. We'll get to that someday. Okay, so diffuse coccidioidal pneumonia. Here is another case. He did have a history of myasthenia gravis. He was on prednisone and Cellcept. He lived in Hawaii, but he did get his neurological care at Mayo Clinic. So when he had two weeks of fever, cough, shortness of breath, and confusion, instead of going to the emergency locally, he flew to Arizona. And he did have one of these diffuse coccidioidal pneumonias, and he was quite old, had a RN daughter who was also driving the care. He was placed empirically on voriconazole, 4 TB meds, lots of antibiotics, antibacterial agents. And I think you could have made a case for amphotericin here. He did have respiratory failure with that x-ray, not surprisingly. He refused intubation, but we eked him through with BiPAP, and I'm still seeing him years later. And he's been on fluconazole 600 to 800 milligrams since that time. So the idea here is treat at least 12 months. Immunosuppressed patients always take longer than that. And I would get to a real long treatment duration before talking about stopping there. There is no endpoint spelled out in the IDSA treatment guidelines. It's not 12 to 24, 12 to 36, or 12 months to 5 years. It's just at least 12. And I would agree with that because some just go slow. Here we have a case of chronic cocci. She started off as a 26-year-old healthy woman in 1972, so you can imagine the type of story we're going to talk about here. She was diagnosed then with cocci. She didn't have any treatment, as would be appropriate, and her symptoms improved. She felt okay, but periodically someone would take a chest x-ray and say, whoa, there's a problem here. But she felt fine. In 1994, her cough recurred, her sputum culture was positive, her serology was positive, and she was treated with amphotericin B and felt better. But thereafter, a few years later, cough recurred, and she went on various trials of fluconazole without really any improvement. She went on a posaconazole trial, and she did improve, but after a couple years, I can't take the side effects anymore. She stopped it, went a few years, and then, or a year, and then came back. When I saw her in 2004, we put her back on itraconazole because she could tolerate it okay. Symptom control was okay, but nobody had any idea that we were trying to do something curative here. So I'm just going to run through some chest x-rays. You can see here she's got a lot of fibrosis and what looks like either bulla or upper lobe cavities. And here is her CT scan. You can see this very large cavity here, and this is not a dropped lung, that's just one really big cavity there. So she almost had no lung at all on that right side. These are very hard to treat. Almost nothing really gets you to an acceptable result, somewhat because you have so much damage already done. So your options are everything we've said, treat a really long time, try to minimize side effects and find something acceptable, or find a trial to enroll in. So real briefly, another case, a 67-year-old woman, Arizona winter visitor. She had some left-sided chest pain, but incidentally in the workup, she was found to have a nodule, and she went to biopsy. And had a CT scan, I'm sure all much to Dr. Empel's horror. But she didn't have any symptoms because the original chest pain had already gone away and probably wasn't related at all. And no treatment was offered. Something similar, asymptomatic cavity, a 35-year-old man. He had a transient respiratory illness, and then that resolved. He, a couple months later, needed a routine physical examination, and a cavity was seen. So everyone gets excited, and they biopsied and did coccyserology. And again, he had this nice little cavity. He's having no symptoms, so we followed it. So IDSA treatment guidelines: asymptomatic lung nodule, asymptomatic cavity, no treatment needed, observe for stability. Okay, so here's a little twist on it, though. This was a 34-year-old woman born in China, came to the U.S., came to Arizona 6 years prior to her presentation. When she was 4 months pregnant, she started coughing up blood and was hospitalized. At that point, she tells me that her imaging showed a cavity, or coccyserology was positive, and she went on amphotericin B, as would be appropriate for treatment of pregnancy, treatment of women who are pregnant with cocci, and her hemoptysis resolved. Following delivery, she's like, I'm done, I'm out of here, and wanted no treatment at all. And I just have some pictures here. This was the cavity that she presented to me with, and it might have looked slightly different when she first had her presentation. That's what it looked like later. So at 2 months, she started having hemoptysis, 2 months postpartum. Her fluconazole then was started, and she had various doses, went up to 800 milligrams a day, but really didn't have a good response. Later, she was begun on voriconazole, and she still had, it was better, but not quite where we had hoped. And she did undergo left upper lobe and left middle lobe wedge resections. She got a little voriconazole after surgery, and her hemoptysis resolved. And you can see not there and didn't come back. So she was very happy. For a symptomatic cavity, optimal duration, don't know. Your options are fluconazole, itraconazole, or consider a surgical resection. Now, some people are highly motivated not to go to surgery, and I think that's fine. They'll stay on azoles for some time. Other people, no matter what you do, end up at surgery because you can't get them controlled. Okay, we've already talked about pregnancy and antifungals. Avoid the azoles. They are teratogenic in the first trimester, and that's a very good time for amphotericin B. You'll find some people, and I don't know, I'm a bit in this camp as well, that will probably end up treating with amphotericin B all the way through pregnancy. But I think that needs to be an individualized decision between the patient and the physician. Immunosuppressed patients often go slower. Things resolve slower. Sometimes you need to, if you can, stop or decrease the dose of the immunosuppressant medication. And there is a higher likelihood that if you choose to stop the azoles, that it will relapse. What I'm seeing now is a lot of people are treating their immunosuppressed patients with Coxi with treatment for the rest of their life. I'm pretty sure it's not necessary that we treat every immunosuppressed patient for life, but I don't think we have any data to figure out which ones can and which ones can't, and which immunosuppressants are okay. I think that would be a really helpful information. There's a lot of people on long-term azoles at this point. And in transplant, the data clearly shows that, that there is a high risk of secondary or relapse after the first treatment, and when it relapses, it often disseminates. The rate of dissemination in transplant populations is 50 to 75%, and there is a high risk of death. So we have a very low threshold for just treating Coxi in transplant patients. I will say for the transplant, though, you'll need to make sure that you're talking with a nephrologist, especially in a kidney transplant, because the doses of fluconazole we need will jack up that prograph level, send the patient in renal failure, and et cetera. Okay, so let me just run through skin and soft tissue infections. And as opposed to the rashes that we've already talked about, this is the fungus in the skin and not a hypersensitivity response. They can look like nodules, they can look like plaques, they can look like a number of things, but most of the time you're going to say, oh, what's that? I'm going to get a biopsy. The treatment here is a really long time. If you look at prospective studies, and these are fluconazole, itraconazole, they had an efficacy level of 60 to 90%. So you'd think, gee, I wish we could do better than that, and I wish we could too. Relapses are really common, and that's no matter if you have an immunosuppressed host or immunocompetent host, the relapses are common. So your options are fluconazole, itraconazole. You can do amphotericin. Most of the time they're not coming in with runaway infection. And like I said, if you're on got a patient on fluconazole, you stop it, the thing is gone and has been gone for a really long time, and then it comes back. You can try a retreatment, but usually when I have the second relapse, then we're talking about cutting that thing off. Because that is the one thing that has worked. If you get a wide enough margin, it doesn't come back. Here is a little baby with what looks like a coccidioidal skin lesion, but in fact an x-ray showed that it was osteomyelitis, all due to Coxi. Here is another picture of a spine that is infected with Coxi. Here it has adjacent adenopathy and big old subcutaneous abscesses, all as a result, and sort of introducing the skeletal infection. Again, azoles show about 60 to 80% efficacy, and this is the only comparative trial here of one over the other. Itraconazole showed superiority to fluconazole in skeletal infection. Relapses are common. Debridement is recommended, and if sometimes someone can't take itraconazole for one reason or another, and so you still can use fluconazole, amphotericin B is still a good option here as well. Duration is long enough and a little longer, and how much do you want to risk a relapse? So, given the data, and I think everyone deserves a time off the medication, but if you're going to prescribe the time off medication because you think you've got it, then you need to watch them very carefully. As you can see, not everybody relapsed. So finally, let me just touch on coccimeningitis. This entity is still one of those entities that studies have shown when you treat and you got everything controlled and you withdraw the azole, you have an 85% chance of relapse, which is really high. So nobody is recommending at this point to treat and then stop. This is not one of those times. We are counting this treatment for life. The workhorse and the standard antibiotic here is fluconazole, and though if you look at the guidelines, it may say start with 400 or higher, and then go up if you need to. I think it is probably true that most practitioners are going with 800, and then with control maybe going down a little bit. 800 is still a fairly tolerable dose. You do have to follow these patients because there is a basilar meningitis. Over time, there could be some hydrocephalus complicating the illness, and they may need a shunt for that. Alternatives to the treatment, intrathecal ampho or a newer azole. So there are guidelines. They will probably be updated soon. I've given you the website where you can find it. Many infections, again, sorry, don't need treatment, but almost all the complicated or severe or disseminated ones will.